and pheochromocytoma. I really wish my device was working. Great picture here, okay? This is something that I always think about. I mean, it looks much better on your screen when you pull it up. I always think about this kind of stuff when I'm doing thyroid surgery, okay? When I'm doing anesthesia for thyroid surgery. Because if you look at that really, really closely, there is a ton of landmines everywhere, okay? What is that? You've been to the Six Flags here. What is that with the Bugs Bunny ride? It was like miners wanted, low pay, danger everywhere. Well, that's your neck, danger everywhere. And that's what I worry about when the surgeons are working and we're doing thyroid surgery, all of the difficulties that they can get involved in. Give it one more second. Okay, we're running my laptop. Sorry guys, I won't be wandering now. The thyroid anatomy, about 20 grams, so not a huge organ. It does have the two lobes and the isthmus. If I have my iPad up and running, I can highlight in here the two lobes and then the isthmus running right in the center. And so when we look at this picture, we realize and even think about when we were doing the cricothyrotomies in the sim lab, you are definitely in an area, in a zone where, bad things can happen. So lots of bad stuff in there. So, and it's connected to the lateral aspects of the trachea. So nerve supply here. So this is stuff, these kind of pictures, you guys have a little quiz that you guys take at the end of all of this, right? And just a little tiny test. This is the kind of stuff that shows up, okay? Things about nerves and whatnot. But what's really, really important on this screen is that we talk about the sensory nerves are just coming from the vagus nerve, the internal laryngeal branch of the superior branch from the vagus nerve. But what's really important, what I really, really, really want to hone in on, right down here, your recurrent laryngeal nerve, okay? So the recurrent laryngeal nerve, if you're looking at the slide very, very closely, that controls all the intrinsic muscles of the larynx, okay, except for the cricothyroid muscle. What does the cricothyroid muscle do? Does anybody remember? I see movement over here. No? Were you motioning anything? No, Todd?
It pulls down the cricoid.
It pulls down, yes, exactly. It pulls down the cricoid, tenses the vocal cords and helps with phonation, okay? But everything else, it comes from the recurrent laryngeal nerve. So if we start looking at our next picture, you can see where the recurrent laryngeal nerve on this slide is coming up from up and underneath. Now the thyroid in this picture is dissected off. The recurrent laryngeal nerve is coming up, underneath, and through the thyroid gland, okay? So that's another landmine. So when you're a surgeon and you guys are doing a thyroidectomy, we're worried about that recurrent laryngeal nerve. You bag both of these recurrent laryngeal nerves, you do that on me, and you wouldn't happen to listen to me going blah, 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 blah today. So you're like, oh great, Dr. Schaefer's being quiet. Just getting into the secretion of thyroid hormones. So you have in your thyroid, you have the follicles, the thyroid follicles. That's where the thyroglobin is. That is where thyroid hormone is made. And then you have the parafollicular cells that are on the outside. Great picture right there. That is where calcitonin is made. We're not going to talk a lot about calcitonin, but I am going to just hit it just very, very quickly. So calcitonin is released in response to an increase in calcium. And it has what they call an anti-osteoclastic effect. And for some reason in medicine, we love all these double negatives, an anti-osteoclastic effect. So what that means, do you remember what osteoclasts are? Those are the guys that are breaking down the bone. I think a little Pac-Man, just chewing away at the bone, taking the calcium, putting it into the blood, osteoclastic. So if it's responding to a high calcium level, and it's got an anti-osteoclastic effect, that means that it's preventing the breakdown of bone going into the blood. It does have a small osteoblastic effect. Remember, osteoblasts, that's the buildup of the bone. So it does have a small effect of trying to get that calcium into the bone to build up the bone, but not a huge effect. And it also has the effect on the distal tubule in the kidney, where, and again, here we go, we talk about reabsorption, and it inhibits the reabsorption of calcium. So if you're thinking about the kidney, we're talking about reabsorption of calcium from the urine into the blood. So it's inhibiting that, into the blood. So basically, it's opposite of parathyroid hormone, okay? The thing that's interesting is that parathyroid hormone, we're going to talk about that a little bit later, is the big dog in calcium control, calcium ion control. And we know that because you have patients that have had their thyroids completely removed, and as long as they still have their parathyroid, at least one of them functioning, their long-term calcium regulation is really not that much inhibited. It just really is okay. So we know that the calcitonin coming from the thyroid gland, from the perifollicular cells of the thyroid gland, is really not super important. A little bit in the control of your calcium ions. So how do we make thyroid hormone? Well, we need iodine. Where's iodine come from?
Diet.
This is easy. Come on now.
Diet.
Salt. Where else? The ocean. Okay. Yep. The ocean. And we're here on land, so we're not, if you're not a big seafood kind of person, we definitely need that iodine in our salt to get our iodine levels. For me, I love Mexican food. I love salting my chips up, so I think my iodine is just fine. And what happens is that we ingest the iodine, whether it's coming from seafood, whether it's coming from our salt. It gets changed to iodine in the GI tract, and then absorbed in the blood, and then it gets to the thyroid. I hear lots. You guys hear all that? Right down there. So can I get, for everybody out here, everybody in here, one big groan for this picture? Does that hurt? That stuff that Dr. Schmidt went over last year, you got pounded into your brain like crazy. So how thyroid hormone is produced. So what we have going on here, and unfortunately I really wish, one more try. Technical difficulties. So what's going on here is that the big dog in this whole production is your sodium potassium pump. You guys have had that ad nauseum. And so that sodium is being pulled out of the cell into the bloodstream, and on the bloodstream side, that's that left side of that picture up there. That sodium is wanting to come back in the cell, a passive gradient. You guys have heard all of that before. And it goes through what's called the sodium iodine symporter. Okay, so it grabs an iodide and says, come with me, let's go back in the cell. Cruises across the cell, goes through the pendrin, and then gets into that follicle that I was talking about. In there, the iodine, through iodinization, couples up and makes those MIT, the monoamine, thyrine, the diiodotyrosine molecules inside the thyroglobulin. And those guys get together through coupling, and they make you've got a mono and a di get together, they make your T3. Get two dyes to get together, they make your T4. So now you've got your T3 and your T4 in the thyroglobulin that's inside the molecule of the thyroid molecule. And then when thyroid stimulating hormone comes down, stimulates this whole thing, and the thyroid globulin is released across and secreted into the blood. Okay, so a big loop there. What also happens is that because it's a very, very small amount of the T3 or the MIT and the DIT, only a small amount of those come together to produce your T3 and your T4, they get recycled back up into the whole system and circled around. So kind of what I was just saying. So the iodine binds to the thyroid precursors and yields that monoiodotyrosine and the diiodotyrosine. Only 25% couples to the T3 and the T4, and the rest of it gets recycled to form your T3, your triiodothyronine, and your T4, your thyroxine. So what's our active thyroid hormone? T3 or T4?
4.
4. How many 4s? How many 3s? Lots of 3s. The 3s have it. T3. Okay. Here you go. What's confusing? So what is Synthroid?
T4.
It's T4. Exactly. So Synthroid that we give patients that are hypothyroid is T4. It gets converted in the blood to T3. So yeah, so T3 is the active thyroid hormone. And when that T3 and that T4 gets into the blood, it comes out, believe it or not, as a 10-to-1 ratio of the T4, but then almost immediately binds to the proteins, okay? And that T4 and also gets converted to T3, and that T4 then gets reabsorbed through the whole system to be used again, okay? So only 1% of all of this equation, only 1% when we're all done, is the free form of T3, which is the active form. Okay, so lots of stuff, and then the rest of it all gets recycled. Another wrong, but a very, very important picture, because if you can understand the negative feedback loops, and we have lots of negative feedback loops in the body, if you can understand the negative feedback loops, that saves a lot of memorizing of tables and forms and stuff later, okay? So real quickly though, so hypothalamus, we'll do a little bit of a review. Let's name off the hormones coming from the hypothalamus. Do you guys remember? Somebody throw one out. Anybody? And then there was blankness. Let's start easy. Does a thyrotropin releasing hormone sound good? Okay, cool. We're talking about thyroid, so there's one. Another hint, they're all releasing hormones. How about gonadotropin, releasing hormone? How about growth hormone, releasing hormone? Okay. Corticotropin, releasing hormone. Somatostatin, dopamine. Okay, those are your hypothalamus hormones that are being released. That stuff shows up. Okay. I was hoping everybody would start just yelling those out, because those things will show up on that little quiz when you guys are done with this program. Okay, what those hormones are. And those hormones are released, and in this case we're talking about thyroid. So that thyrotropin releasing hormone is released from the hypothalamus, goes down to the anterior pituitary. And before I get any further with that, do you remember your anterior pituitary hormones? Anybody? Out loud, a little louder for me. Don't be shy. How about things like growth hormone, luteinizing hormone, thyroid stimulating hormone, ACTH? Those all ring a bell? Okay, we need to remember those things. Okay, and we're talking about the thyroid stimulating hormone. What's the other name for the anterior pituitary? The Nino hypothesis. Very, very good. Excellent. Good deal. And then just for fun, even though we're not going to talk about it, so the posterior pituitary has 2 hormones. Do you remember those? Oxytocin. And what was the other one? ADH. Exactly. What's the other name for the anterior, posterior pituitary? The neurohypothesis. Okay. Why is it called the neurohypothesis? It's got a neural connection with the hypothalamus. Remember in this picture, as we're looking at this picture, the hypothalamus to the anterior pituitary is all hormonal. It's the hormones that are controlling what is being released from the anterior pituitary. Okay? The neurohypophysis is a neural connection, so kind of an easier way. So ego hypothesis, fancy name, and neurohypophysis. So on this negative feedback loop, what goes on is that the body needs thyroid. Okay, so the body's low on thyroid, and so the hypothalamus starts sending down that thyrotropin releasing hormone to the anterior pituitary. The anterior pituitary says, "Oh yeah, I've got to release thyroid stimulating hormone." It comes back down to the thyroid to start through all of that stuff that I just talked about, to start with the releasing of the T3 and the T4. Once we get enough of that, it comes back around on the other side and tells the hypothalamus, I got plenty of T3 and T4, I don't need any more, and the whole thing shuts down. Okay, so that nice negative feedback loop. But that if we understand that loop and what's going on, then we don't need to memorize charts that talk about, well, what are my lab values and hypothyroidism and whatnot. We'll chat about that here in just a second. So what does thyroid hormone do? Does anybody remember what thyroid hormone does? You guys are just like, are you like so tired from clinical? I see Cooper falling asleep right here. He's almost snoring a little bit of drool, you know? What does thyroid hormone do? I think of thyroid hormone because it has beta effects. It jacks you up. Easy way to think about thyroid hormone. It jacks you up, okay? And if you can just remember that, if it's increasing metabolism, if you can think about it that way, if it makes you hypermetabolic, then heat generation makes sense. So somebody that is hyperthyroid would be somebody potentially, this is an exaggeration, but potentially, you know, I come from Colorado, and I had friends that were out there in the middle of winter, and they're wearing their shorts and a short sleeve shirt, and I'm all bundled up in a down jacket and hoodie and the whole 9 yards. And I'm sure that they probably have a little bit higher level functioning thyroid, I don't know, but than I do. So heat generation. Your basal metabolic rate is up, okay? So you're gonna have, your ATP is cruising. Ions, your calcium, your sodium channels, you have direct effect on the ion, on those channels and on those channels in the heart. So your ions are changing quite a bit, okay? Like I said, BMR, protein synthesis up, and regulation of your fat and your proteins. All of that is jacked up. You're hypermetabolic, okay? You're jacked up. So if somebody's hypothyroid, what's the very, very first sign of somebody that might be hypothyroid? Abby. Abby's cold all the time. I suggest she gets her thyroid checked. Okay, bundled up here. Cold intolerance. Okay, first sign of hypothyroidism. So that T3 has a direct beta effect on the mitochondria, on the myosins, on the beta receptors, like I said, on the calcium, the sodium, and the potassium channels. So you see that left ventricular contractility increasing. You see your ejection fraction increasing. You see your heart rate's going up. So you get that higher blood pressure. That can lead into the heart failures, the AFibs, and the dysrhythmias. We think about the dysrhythmias because of the channels, the ion channels are not functioning correctly. So the bottom line is that with the increased contractility and decreased SVR. Another grown picture, because again, this is the kind of stuff, again, and the reason I show it to you here, because I do know, and we chat with the students. I'm just hearing so much echo. Okay, we'll keep going. We hear from the students that are just taking that little exam that I keep talking about, and they're coming back and they give us little hints of what's on the certifying exam, and these things show up. Okay, these anatomy questions. So, vagus nerve, that's where your parasympathetics are coming down. the fibers coming down to the thyroid, and then the sympathetic side is running down with the blood vessels from the sympathetic ganglion in the trunk there. Remember, as we're talking about this stuff, we talked about the adeno hypothesis. Thyroid is controlled by hormones, not by blood supply. So you guys out in out here, are you hearing me okay? We have yeses or nos, we're okay?
I hear like a machine, like it sounds like we're listening to a really bad murmur.
I have no more. Can you guys help me out in here? Because I hear it like crazy. Somebody have a mic on? That sounds better. Is that any better?
It's your time moving.
A little bit better? Okay. Because I'm hearing it like crazy, so.
Can you move around real quick? Because I think it's the mic on your tie that's making the noise whenever you're walking.
Okay, let's try something else here. We're gonna have trouble with that one, right? How about if we try over here? Is that any better for folks?
No, that's worse.
That's worse. Why am I having so much trouble today? Dr. Henderson? Try one thing. Okay. Right here. Try that. Is that helping you guys out there? I'm not hearing it as much now. Is that better? Maybe?
Yeah, that's better.
Is that better? Okay, sorry about that. So we were chatting about innervation, and I was telling you that remember that the thyroid is controlled by hormones. So all of this innervation is all about blood supply to the thyroid. But take a look down there at the bottom. We talk about the superior, middle, and inferior ganglia. Think about those three words, and it makes things simple because as I go to the vascular supply, all of a sudden you're going to see superior, middle, and inferior again to help with remembering these things. Arterial. Wow, superior, inferior, thyroid artery. Pretty easy to remember right there. Also, some folks have what's called the thyroidema. That is a remnant, that is an accessory blood supply. It's sitting down there, you can kind of see in your picture, and you can see it better on your computer screens, I'm sure. Blood supply that goes to the thyroid. Not everybody has a thyroidema, but it is an accessory vessel that goes to the thyroid. And that does come off the aorta and the subclavian. So, vein. Hey, look at it. Superior, middle, inferior. Again, thyroid vein. So pretty simple stuff right there. And then we talked about that negative feedback loop. So we didn't even need to memorize this chart, okay? Because if we look at hyperthyroidism, so hyper means your levels are up, so our T3 and our T4 are up. We think about that feedback loop coming back up to the hypothalamus. The hypothalamus is now saying, we don't need any more thyroid, we don't need it. And so your thyroid stimulating hormone is lower and it comes back around. Primary hypothyroidism. Don't even need to memorize the chart again, okay? Because we think about primary, so I think about primary would be in the thyroid itself, okay? So hypothyroidism, so we know that the numbers are going to be low, decreased and decreased. Well, that makes sense. Thinking about that negative feedback loop coming around, so our numbers are low. The hypothalamus is saying, oh my gosh, I need more thyroid, I need more thyroid. It's spitting out the thyroid stimulating hormone. Boom, your levels are up. And then for some reason in the thyroid, you're not getting your thyroid, your T3 and your T4. Secondary hypothyroidism. So secondary somewhere else. Primary in the thyroid, secondary, probably the hypothalamus. So again, that negative feedback loop that we were talking about. And now the hypothalamus is not spitting out the thyroid stimulating hormone to tell the thyroid to release the T3 and the T4. And all of a sudden, hey, look, thyroid stimulating hormone low, all your other levels are low. And then just real quick on pregnancy, the thing that's really amazing about the human body and pregnancy is that thyroid hormone is attenuated in pregnancy. Okay, so ladies that have like a Graves' disease, hyperthyroid, and they get pregnant, for some reason, somewhere along the line, somebody somewhere that was making us realize that the drugs that we would create for that disease process are really, I mean, they suck for the baby. Okay, bottom line, they suck for the baby. And so they were smart enough, however this all happened, to know that pregnancy should attenuate your thyroid disease. And your numbers usually stay pretty normal, so you can have a lady that is hyperthyroid, she gets pregnant, and all of a sudden her numbers kind of get better. Kind of cool stuff. Stuff that you see on your scans before surgery, when you're taking care of patients that are having thyroid surgery. That top left one, the normal, so this is all your radioactive iodine scans, your iodine 1, 2, 3, or technetium. You can also see this stuff with ultrasound, but you can see with the normal scan, that top left one, the thyroid, the two lobes of the thyroid are picking it up, you know, the iodine pretty well, not huge. As soon as you get into somebody that's hyperthyroid, like Graves' disease, really lights up. Down here at the bottom, the toxic multinodular goiter, splotchy, it's all over the place, and then unfortunately, big blob with the adenoma. So, but you'll see these scans. So when you see these scans, you'll be able to look at that and go, this really does look like they got Graves' disease or TMNG. So I looked at this slide this morning, and I got hyperthyroidism. And then what's my next line? Hyperfunctioning of the thyroid. It's like, come on, Dr. Schaefer, do you really need to have that on your slide? Okay, I don't know. I looked at it this morning, I was like, well, it's too late to take that off. So, but the typical diseases, Graves' disease is the most common form of hyperthyroidism, the goiters and the adenomas. So remember, we were talking about thyroid. Remember, I said that these folks, that the thyroid makes you hypermetabolic. So as we start thinking about what's going on and what would be the signs and symptoms of hyperthyroid, and this makes sense. If you're hypermetabolic, you're going to have weight loss, you're going to have the diarrheas, you're going to have the weakness, you're going to be warm, you're going to have heat intolerance. That all makes sense because we now know what thyroid hormone does. And then exophthalmos. Remember exophthalmos? Big, huge, puffy eyes. I got a great picture of that here in a minute. And then cardiac symptoms. Again, since we know now what thyroid hormone does, we know because it's got a direct beta stimulation on the heart that you can get the tachycardias. And we know that it disrupts the sodium and the potassium channels, that we can get dysrhythmias, we can get the palpitations, increased contractility, beta stimulation, increased cardiac output. And then I've got down here cardiomegaly. So think about it this way. So you guys, I bet a lot of you are still exercising. I personally try to avoid it at all costs. But and some of this, you're still exercising. You're out there. You're getting aerobic. You're getting that pounding heart. You're building up that heart muscle. That's a good thing. And think about the person that's hyperthyroid or Graves' disease. They've always got that contractility. They've always got that beta stimulation, and that will lead them to the possibility of cardiomegaly. There he is. Anybody know who this is? Dr. Henderson, do you know who this is?
Familiar with the face.
You're familiar with the face. This is Marty Feldman. He was in, anybody seen the movie Young Frankenstein? Okay, there we go. So who was he in Young Frankenstein?
He's a little.
He was Igor in Young Frankenstein. Exactly. Okay, this is classic Graves' disease. Igor, I know you guys are busy. work in clinical and stuff like that. This is Young Frankenstein was like in the late 70s, I think. I really recommend you watch it because it's absolutely hilarious if you know anything about the typical Frankenstein movies. So yeah, exactly. So Marty Feldman, there's your exophthalmos right there. So Graves' disease is the leading cause of hypothyroidism. It's definitely a girl disease more than a boy disease, and it's a young person disease. So unfortunately, even though I showed you Marty Feldman, he's a guy, and he's probably in that picture, he might be 40 or plus, I'm really not sure. We don't really know exactly what causes Graves' disease. We do know it's an autoimmune disorder. We do know that the body is building up antibodies to the receptor, the TSH receptor in the thyroid that is causing the thyroid to produce all of that T3 and that T4, okay? And you can get the goiters with this disease. Now, Marty didn't have one in that picture. He might have had one later. I'm really not sure about that, so. So the toxic multinodular goiter. So this is a little bit of an older person's disease, a little bit older. 40 is young to me, but that's okay. These guys can have an extreme goiter. So think about those patients that come in with that extreme goiter. And I've got up there dysphagia and stridor. Does that kind of make sense? You've got all of that extra real estate up in your neck. So it's going to be pushing on the esophagus. It's going to be pushing on the airway. And so anesthesia-wise, we start worrying about difficult airways with these folks, okay? And the key here also is that, I think I had said, if I didn't, I'm saying it now, that toxic multinodular goiter is typically benign, okay? But they present kind of the same way thyroid cancer, thyroid adenoma presents, okay? So what happens in the OR when we're doing these cases, when you guys, who's done thyroid stuff here? A lot of people have done thyroid stuff, so you've seen this stuff where you're in the OR and working away, and you get down and the surgeon gets the thyroid gland out and you send it off to pathology, right? And then what happens, what I've seen with my ENT surgeons, the specimen goes off to pathology and they continue closing, okay? Waiting on the results of pathology. Do you guys wait, or does your surgeon usually start closing? You said waiting? Okay, yeah. So you'll find it too, a lot of surgeons will want to just continue, they'll close, they'll start closing, okay? They'll get completely closed depending how fast pathology is, and they'll go sit down over here waiting, okay? Well, anesthesia, what are we doing? All of a sudden the stimulation has gone way down, so we're cutting everything down. We're getting the patient really, really, really light, getting ready to wake them up. Phone rings. It's pathology, and they come back and they got one or two answers. Either we've got all the margins, we're good, or we don't have the margins and you need to go back and get some more. So they say they don't have margins, we need to get some more. I see this with my surgeon, my ENT surgeon. He jumps up and runs to the table and wants to start going right away. And I'm sitting here glad that I was paying attention to what he was saying on the phone, so that I know I now have to be pushing some propofol or turning up the gas, getting that patient deep. Because remember, with your thyroid surgeries, you typically don't have them paralyzed. So we got to get them deep quick. So you got to be paying attention to what's going on. And get them deeper, they're going to try to jump off the table, okay? And you lose saddle points for that. So when your patient tries to run out of the room and you're not quite done yet. So flip side is they get the margins. And I know my ENT surgeon will jump up, throw his hands in the air in victory, and then start squawking it up saying, come on, let's go, let's go, let's go, let's go. We got to get going. We got to get the next case going. Hurry up. Come on, let's go. Why is the patient not awake, Scott? Come on, hurry up. I got a tea time today. Let's go. And you got to remember, hey, I let you do your part of the deal. Let me do mine. And slowly, confidently, quietly finish waking your patient up. There's that extreme goiter. The thyroid surgeries, have people done stuff this big? Yes, no, maybe, yeah, exactly. Yeah, that's scary. Does that scare you guys? That scared the heck out of me. Looking at that picture. So first thing I'm like, okay, where's the tube gonna go? So how do we treat hyperthyroidism? Hypothyroidism, PTU, okay? Great drug to be using. And it interferes with the synthesis of the thyroid hormone and inhibits the conversion of the T4 to the T3 in the blood. Here's two problems with it. One, takes a while to kick in, 6 to 8 weeks. And two, can cause agranulocytosis. What's agranulocytosis? You guys remember? White blood cells, granulocytes, right? Okay, shaking some heads here. So you have somebody that has had Graves' disease, they've been on PTU for a while, they're coming in for whatever surgery. What's something that you're thinking about in the back of your mind if they might have agranulocytosis? Your skip protocols, infection, you're higher risk of infection, that kind of deal. So be thinking about that with somebody that's on PTU and for Graves' disease. Iodine. It inhibits the release of the hormone from the gland. What did I say earlier today? Did I say something that conflicts with that? Right at the beginning of this lecture? Didn't I say you need iodine to make thyroid? And now I'm saying iodine inhibits the release of thyroid. Does that sound crazy? Am I going to get a phone call or an email that says, Dr. Schaefer, you said on slide number 4 at 2:07 p.m. that iodine is needed for production of thyroid. And then you said on slide number 34, and they need to hear. So that comes from this Wolff-Chaikoff syndrome or whatnot. These are the guys that realized it. And they realized that if you give them excess iodine over on that follicular side, remember that picture that I was showing you on this side? That iodinization that I was talking about, converting the iodine into your MIT and your DIT, it inhibits that process on that side in excess amounts, in high dose amounts, okay? But the problem is that the iodine is also short acting. It acts quick, it's fast. You get it in there, it will get your levels to go down. But it's also short acting. After about 10 days, it doesn't work anymore. It stops working. And so there's what they call an escape phenomenon. And what we've realized is that after about 10 days, all of that work on the one side of the basal membrane starts to inhibit on that NIS, that sodium iodide symporter that's on the other side of the basal membrane. That starts to get inhibited, and you don't have the iodine coming across at that point in time. So after about 10 days, you get that inhibitory effect. So onset fast, works great, but it will only last for about 10 days. And then beta blockers. And so do beta blockers fix thyroid disease? No, they don't. Okay, but they do take care of all that beta stimulation that I was talking about that you can get from thyroid hormone. Okay. Now the one thing about propranolol though is that it does impair the conversion of T4 to T3. So, but it's not solving the underlying problem, it's treating the symptoms. Glucocorticoids, another treatment for like a Graves' disease that will inhibit the conversion of the T4 to the T3. Radioactive iodide. So this is great, it works. 80% of the time, people are cured. Flip side down here, about 70% after 10 years, these patients go all the way over to the hypothyroid side. And then the last one up here is surgery. That's the one that we see, that you guys have seen doing these thyroid surgeries. This is awesome. 95% remission, and what's even better, 30% after 20 years. So pretty good effect, pretty good results. The deal is, you have to outweigh the risks and benefits of having surgery and anesthesia and whatnot compared to a little bit better of a result. kind of talked about that earlier. So you want to get these folks euthyroid beforehand, okay? If somebody's not euthyroid, if they're still really hypothyroid, really it's time to try to maybe think about not doing the case, depending on what the situation is. You're really shooting to try to get them as close to a normal thyroid levels as possible. And then really take a look at this picture, and you can see, and you can see it up here, but you can probably see it really well on your screens, that deviation of the trachea, okay, from some sort of goiter that's in there. So again, remember, we know what thyroid hormone does. We know that it has beta effects. So we're going to do everything we can to prevent sympathetic nervous system stimulation, okay? So we don't need any more of that. We've got enough of that going on. So ketamine, probably not a great idea, is the sympathetic. Make sure they're deep, of course, and then you can definitely, you want to use alpha stuff for hypertension, okay? And I have here on here, why would somebody still need beta blockers for a week afterwards? We've taken the thyroid out. We got the problem solved. So you still have hormone that's running around, okay? So you still might need to treat their symptoms with some beta blockers for a little while to help things preserve. And then the other thing, remember I talked about Graves' disease being an autoimmune disorder? And so I start worrying about other things that are autoimmune disorders, because if you have one autoimmune disorder, you're prone to have other ones. So maybe myasthenia, those kind of things, so muscle weaknesses, those kind of deals. So when you guys were doing your thyroids, were you using NIMS tubes? Yeah, exactly. No, we said no and yes. Do you know what NIMS tubes are? This is a neat little video that I just want to show you guys. It comes right out of Barish. And so if you have the online version of Barish, you can actually see this. But let's see if this is going to work for you. Since all my other technical stuff is messing up, let's give it a whirl.
The nerve integrity monitoring electromyography interpreter tube is a silicone tube fitted with two wire electrodes exposed anterolaterally, designed to make contact with the patient's vocal cords. This endotracheal tube is used for intraoperative electromyographic monitoring of the vocal cords to ensure intervention integrity during surgical procedures such as thyroidectomies. This monitoring function of the NIM tube does not work properly in the presence of neuromuscular blockade or local anesthetic lubrication of the tube. The tube's diameter should be large enough to allow electrode contact with the vocal cords. In this case, we're using a glide scope to visualize correct placement of the tube, which is essential for accurate electromyographic monitoring. The area of electrode exposure is demarcated by a blue band. This area must be in contact with the vocal cords. The tube should be secured in the midline to minimize the possibility of unilateral contact. The red electrode should be on the right and the blue electrode on the left. These endotracheal tubes require additional electrodes to be placed subcutaneously. Proper connection of the electrodes to the patient interface is essential, and it is the surgeon's responsibility to assure that this is properly done. This patient underwent a thyroidectomy. Complications related to thyroid surgery include hematoma formation. Thus, it is important for the patients to experience a smooth emergence without bonking, coughing, or straining the anterior muscles of the neck.
So, yeah, I've been doing anesthesia long enough that we started out without the NIMS tube. I think it's pretty common, or getting to be pretty common everywhere. So that you're monitoring the function of the vocal cords. So if we're stimulating, what was that nerve that I was talking about? Oh, the recurrent laryngeal nerve. If the surgeon gets near that, it stimulates that. It'll make that vocal cord on that side move. It touches the electrode and makes a really loud, obnoxious, folks that use it, that loud, obnoxious noise that goes on, right? Shaking your head. Yeah, exactly. So, so good stuff. So afterwards, hypothyroidism, so you've taken out all of the thyroid, so complications, hypothyroidism, tracheal compression. I think the video talked about bleeding and edema and swelling, so we're worried about that. The recurrent laryngeal nerve damage, And so just, I don't think that they're doing this anymore, but I remember though starting, it used to make me laugh actually. Because the surgeons would want us to extubate the patient, do a direct laryngoscopy and look and see if the vocal cords are moving. And if they weren't, then we'd put them back to sleep, they'd go in, they'd spend another 2 hours searching for the recurrent laryngeal nerve that was damaged. 99.999% of the time, they either couldn't find it or they couldn't repair it, and we'd wake them up anyway. So, but the NIMS tube really has made that a lot better because they really can tell when they're getting very, very close to that recurrent laryngeal nerve. And then, as we're going to talk about, the parathyroid glands are on the backside of the thyroid, so inadvertent removal of the parathyroid glands and calcium issues. So. It's been about 53 minutes or so is what my timer is saying. You want to take a break for a little bit? Take about 10 minutes. So I talked about the expectation in class, but with the exams, please let me know so that we can make some adjustments and whatnot. Because I want you to make sure that you're scoring well on the exams and not having any issues there. So, cool? I get a little credit for that innovation, don't I? And I thought that'd be good for coming back from the break and waking up a little bit. So thyroid storm. So this is a life-threatening situation. It's an exacerbation of hyperthyroidism. Okay, it is brought on by trauma and infection and illness. So in the OR, it can look like MH. Okay. In the OR, if you're seeing something that looks like MH, I would treat it as MH. I would rather the patient get some dantrolene when this is thyroid storm versus treating it like thyroid storm and not get their dantrolene. Okay? Even though there's a 20% mortality rate, malignant hyperthermia is a much worse kind of deal. So what's going on from that trauma, infection, illness, or whatnot, is that remember that when I talked about previously, 80% of the thyroid hormone is bound by protein. And so there's a shift from those, shall we say, insults to release the hormone from the protein into the blood. Back to working again. Miracles do happen. You typically see this stuff after an emergency surgery, okay? Not necessarily thyroid surgery. You usually see it after surgery. It's happens with folks that might have underlying Graves' disease that we don't know about. We're going to treat it. These things going back to what we know about thyroid hormones. So the cooling makes sense because they're hypermetabolic. Hydration, beta blockers, dealing with the symptoms, steroids, anti-thyroid drugs. So a little bit earlier I talked about PTU. Would PTU be a good choice for thyroid storm? Yeah, probably not because it takes so long to kick in. So, question or?
Oh, you mean hydration, correct?
Did I say
No, I think on our slide it just says dehydration.
Oh, yeah,
hydration?
ours says dehydration.
It's hydration, but a typo on our notes that
Right.
you posted. Yeah.
Yeah, you need to treat them with hydration.
Don't be.
Does your slide say different? What's
It
the,
says dehydration.
your slide says
Yeah, it
dehydration?
says to dehydrate.
Oh, I know exactly why too. You got last year's slides. That's wrong. Thank you, Abby. Thank you. Mary. Hydration up here. This is correct. Your slides are wrong. So thank you for correcting that. So obviously you got last year's slides. Oh, okay. Hydration, cooling, beta blockers, steroids, anti-thyroid drugs. Okay. So we decided PTU not a great idea. Probably your iodine because it's fast, short acting. Probably a good way to treat this right off the bat. an old nursery rhyme that none of you will remember, but the cartoon kind of sums it up. You got Mr. and Mrs. Spratt, hyperthyroid, hypothyroid. Great picture up there of them. Does anybody remember nursery rhymes? No? Okay. Oh, well, cold deal. So Jack Spratt could eat no fat, his wife could eat no lean, but between the two of them, they'd lick their platter clean. Somebody, Kaylee, you're shaking your head like you've heard that before. Primary hypothyroidism. So again, when we were talking about primary and secondary before, primary and hypothyroidism would be in the thyroid. That's 95% of the time. That's the Hashimoto's thyroiditis that we see here. And then secondary up in, again, not in the gland, so it must be up at the hypothalamus, so that's only about 5% of the cases. A pituitary adenoma or some sort of weird pituitary abnormality that is not releasing the thyroid stimulating hormone. And ideology is another autoimmune, but we don't really know anything too much more about it, or I don't. Most of these cases of hypothyroidism are subclinical. But it's all about, we talk about what thyroid hormone does. So if somebody's hypothyroid, the exact opposite. We're on that flip side now. We're in that where they're tiring easily. They're gaining weight. Maybe that's my problem. Slowing down, speech, intellect, cold intolerance over here. Constipation, the GI tract is slowing down, muscle stiffness. And then we worry about that perioral and orbital and facial swelling and peripheral edema. So if we start getting perioral edema, airway issues. So somebody hypothyroid, I'm just in the back of my mind thinking airway issues. Again, jumping onto the cardiovascular side, we know about thyroid, so we can easily transfer over and go, okay, so if I don't have enough thyroid, and I know that thyroid has all that great beta stimulation, what's the reverse effect? Your bradycardias, your dysrhythmias again, contractility is now down, labile blood pressure, heart failure. Treatment. Here's your T4 that we were talking about earlier. Okay, your Synthroid, your levothyroxine. And it's identical to T4. And so we start thinking about that negative feedback loop. And what we're going to be monitoring for is our thyroid stimulating hormone levels, okay, because of the negative feedback loop that we were talking about. It takes a little while for this to kick in, half-life, about a week or so, but it takes a full effect takes about up to 3 weeks. Hypothyroid, usually you don't need to cancel these cases, okay? But again, airway, and thinking about the fact that now these folks are the ones that have slowed down, they're hypodynamic, so they may have some CNS depression, they may have cardiopulmonary issues, skeletal muscle weaknesses again, adrenal insufficiency, hypothermia, being cold all the time. So adrenal insufficiencies, these are the folks that you may be considering a little bit of steroid supplementation before induction. So, mixed edema coma, this is kind of funny, because I was working on this slide a couple days ago, had it up on screen, and Dr. Chubog came by my office and he saw that. And he saw mixed edema. Oh my God, Scott, that is so great. I'm so great. Glad you're talking about that. That's awesome. I guess because some of the students, he's really monitoring the folks that are taking the test right now. And they were saying that this stuff was on the test. Okay, but it was just kind of funny. I mean, this was just a couple days ago that he was like, "I saw, you know, Dr. Chubog. Oh my gosh, that's so awesome! We'll get you treated. Glad you're doing that." So, rare form of severe hypothyroidism. Again, we're talking about these patients being hypometabolic, very, very depressed, as in coma. So they can be so depressed they're in coma. It's usually older women that have maybe not even taking their thyroid medicines that have been hypothyroid. Infection usually kicks it on, and this is definitely something that the endocrinologists really need to get on board and get something going because there is a high mortality rate with it. So, and the hallmark sign is that decreased level of consciousness and hypothermia. So great little picture to look at, kind of sums up all the body systems where somebody with mixed edema coma, we kind of hit on some of that stuff, so we'll just let you look at that at your own leisure. Treatment, IV thyroid, T3, T4. Hydrate these folks and warm them up. And remember, they are so depressed that sometimes you're going to get intubated and ventilate them and use supportive measures and ventilate them. Get some steroids on board, okay? And you use steroids until you ruled out renal insufficiency. Because remember, everything is depressed. Jump into parathyroid. When I talk about parathyroid, we're going to be talking about the calcium. How we control calcium. I included on Blackboard, it was a one-pager out of Nagelhoff, I think it was, that talks about the control of calcium, that explains it. So if I'm explaining it here, it's not making sense, please take a look at that. Some of the students have, in the past have thought that that was helpful, so you can take a look at that too. So the parathyroid, 4 parathyroid glands on the back of the thyroid, and it looks exactly like this picture. Has anybody done the parathyroid surgeries? I got a couple nods here. Did you guys do assays with parathyroid surgeries? Yep, okay. Was that kind of cool? Did you have an A-line in to get all that blood? And exactly, because they're down this way, and there we go. Very good. Okay, so I'm getting it right so far is what you're telling me. And when they were pulling the thyroid back, it looked exactly like that, didn't it? Those 4 little parathyroid glands, boom, 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 just like that, right in the picture? No. Oh, when I've seen it, I see the little, looks like little fat globules, and I have no idea what I'm looking at, kind of deal. They say there's 4, sometimes there's 3, sometimes there's 5, which gets us in trouble, or can get us in trouble when we're doing, say, thyroid surgery, and your surgeon is going to say, okay, so I'm going to do a subtotal thyroidectomy. I'm going to leave a little bit of the upper lobe there so that they have some thyroid function. And I don't need to worry about the parathyroids because they got 4. There's going to be 1 up there at the top. It's going to be okay. And then we realized that that patient only had 3. And we start having the calcium control problems. So I think I just said this, the 4 glands produces parathyroid hormone, that makes sense. There's some normal lab values for you. So another feedback loop, okay? We chatted a little bit about the calcitonin at the top. Calcitonin is responding to too high of level of calcium, so it's got that, inhibits osteoclastic activity, inhibits the breakdown of the bone, putting calcium into the blood. It inhibits the GI tract from absorbing calcium, and it decreases the reabsorption. There's some double negatives again. Decreases the reabsorption of calcium ion from the distal tubule. So parathyroid is the exact opposite, okay? It's responding to low calcium, so it's coming over. It is stimulating the osteoclastic activity. It's breaking down the bone, trying to get the calcium into the blood supply, okay? It's increasing the calcium uptake from the intestines, and it's increasing the reabsorption of calcium out of the distal tubule into the blood to increase your calcium. And here's another one. So we know that the ionized, which is the functioning calcium, 50% of it is ionized, okay? 41% is protein bound. So what we can take away from this, what we've noticed is that, so if you have somebody, you increase their proteins, they get more albumin or whatnot, you'll get an increase in your total calcium, because you know when you look at lab work, you look at total calcium, you look at ionized calcium. The ionized calcium is the calcium that is the functional calcium, okay? We look at total calcium, we look at ionized calcium. When somebody has increased proteins, your total calcium will go up, but your ionized portion stays about the same. You don't see as big of effect by increasing your proteins. But the flip side, alkalosis increases protein binding of calcium. Alkalosis increases protein binding of calcium. So we start thinking anesthesia-wise, well, we don't really mess with anybody's electrolytes. Why do I care about this, Dr. Schaefer? And I say, wait a second, think about this for a minute. It's your first day of clinical. We're excited, first day of clinical, it's awesome. We're scared, okay. You push your propofol, feeling pretty good, patient's asleep, push my rocuronium, feeling good, I'm scared. I got that great mask fit on there. Your CRNA is like, slow down. You got all that hyperventilation. You're blowing off that CO2. You're blowing off that CO2, you're causing a little bit of alkalosis. So, in a simplified version, you're blowing off CO2, you're potentially blowing off calcium. Okay? Or the flip side. Now you're really comfortable. You guys have been at this for 6 months now, 5 months, 6 months. Now, you're feeling good, we're feeling cool, we're doing this mask case, life is good. There's my breath for the patient, everything is great. There's my breath for the patient, we're all good. There's another breath for the patient. Oh, I gotta get some propofol out, okay. Here's my propofol. Drop that up. Oh, I dropped it, darn it, okay. Let me get that cleaned up here a little bit. Okay, cool. Let me drop some more. Oh, darn it, wait. I'm supposed to be ventilating the patient. Flip side, all of a sudden this patient is getting hypercarbic. The ionized calcium is being affected that way too. So we can affect calcium. In a normal, everyday, healthy person, probably not a big deal, but somebody that we might be worried about calcium, this could be a potential big problem. So hyperparathyroidism, increased parathyroid hormone, yep, exactly, elevating your calcium. So primary, again, we talked about, like when we talked about thyroid, primary and secondary. So primary, adenoma of one gland, secondary can be renal disease or whatnot. So we metabolic endocrine neoplastic syndrome that I'm not even going to go into because that's a complete several lectures right there. So you can see these folks with that calcium getting pretty high, okay? This is the ionized calcium. So all the symptoms, of course, are related to the hypercalcemia. Conduction issues, okay? Bone pain, think about that. So you've got that huge amount of osteoclastic activity, that little Pac-Man that I was talking about, chewing on the bone to get that calcium into the system. Bone pain, fractures, because now the bones are getting brittle because of all of that osteoclastic activity. Somnolence, anorexia, kidney stones, extra calcium. So one of the little mnemonics that some people use is they talk about this bones grown stones, bones thrones, and psychic overtones. So these are the patients that just don't feel good. It's like, I don't know why, I just don't feel good. I'm kind of achy, I just feel, things hurt, I just don't feel good. And they go to their doc, and the doc is like, well, I think you have the flu, and that doesn't work, and things get worse, and they just start to kind of get depressed, the psychic overtones, because they just don't feel good, okay? Polyuria, there's your toilet, your thrones, stones, kidney stones. So bones, groans, stones, bones, thrones, and psychic overtones for hyperparathyroidism. How are we going to treat it? Hydration, diuretics, hemodialysis, and then, hey, look at this, calcitonin. Wow, okay, so I told you calcitonin doesn't have a big effect on your control your calcium levels, but kind of like the excess iodine, that if you're starting to give extra calcitonin, you can help with the hyperparathyroidism. So the definitive answer to hyperparathyroidism, surgery, getting it out. That's where they come to see us. Removal of the offending gland. These patients are going to sleep, probably an IMS tube. Remember, they're having calcium issues, so they might be a little bit more, they might have weakness, they might be a little bit more susceptible to our neuromuscular blockade, so definitely titrating if you're using muscle relaxants. But then typically, if you're using the IMS tube, you're gonna let your muscle relaxants wear off and go from there. Hydrating these folks, getting their urine output up. Positioning, really, really, really important. Again, remember all that osteoclastic activity. Remember breaking down of the bone. These are the folks that were doing this parathyroid surgery. We don't position them very carefully, and all of a sudden they have some sort of fracture that was because of us with poor positioning. You lose points for that. And then we were talking about the assays. So what happens when you're doing parathyroid surgery is that you get in there, you definitely want an A-line, not so much for, necessary for monitoring, blood pressures and whatnot, but you're gonna be drawing a lot of blood, okay? And they're working on the neck, so a lot of times arms are tucked, so you need a good way, good access to draw blood. And so before they clamp and ligate the vessel to the thyroid, the parathyroid, we're gonna draw some blood, we're gonna send it off to the lab, and we're gonna get a baseline level of your parathyroid hormone. When they ligate the vessel coming from the parathyroid, we're gonna draw blood again, send it off, and we should start seeing a decrease in that parathyroid hormone. And so we feel like we're doing great, so we're gonna go ahead and continue taking apparatus for the parathyroid. And typically within about 20, showed you it's not technical. And you guys have seen this, you've been in the OR enough now. So hypocalcemia, I just got this up here, and this is kind of for me. I can never remember. I remember the blood pressure and stuff. I always forget which one is Chicago-Fitz and which one's Trousseau's for hypocalcemia. And then also laryngospasm. So hypocalcemia can have the laryngospasm. So that's something we think about in the recovery with patients having a laryngospasm. We're going to be treating the laryngospasm like it's a laryngospasm, but we're also thinking thyroid surgery or parathyroid surgery. How bad did I mess up the calcium control? How do you treat it? We're going to treat it with somebody that has hypoparathyroidism, so their parathyroid is down or their tissue is resistant to it, so they're going to have the low calcium, okay? So how do we treat it? We treat it with IV calcium. I just put up here as a little trivia question, if you guys should get it just like this. Gluconate or chloride? Chloride? Final answer? Chloride, how come?
3 times more.
Pardon me?
3 times more potent.
I still didn't hear you.
3 times more potent.
3 times more potent. What does it do in a peripheral IV? Is it really, really hard on the vessels? Gluconate's easier on the vessel. It's 3 times more potent. The chloride is 3 times more potent. You're absolutely right. But typically you'll stick with gluconate because it's easier on the vessels. So, cool. hyperparathyroid, hypoparathyroidism. You guys can, I'm not just gonna read that slide to you, you guys are adults, you can take a look at that. Pheochromocytoma. So catecholamine secreting tumor of the chromatin cells of the adrenal glands. Who's done a pheo? You're the only one? There you go. We talk about pheo and anesthesia all the time. But only one of you has done a pheochromocytoma. It's not super common, okay? And I heard today that Dr. Chubak, for some reason, was talking about pheo, wasn't he? Did he bring that up today? Pardon me? Okay, gotcha. So not super common, but we talk about it partly because it's very, very cool. So you have it, but it's a cool scientific concept to be thinking about with your beta blockers and your alpha and beta receptors, okay? This is potentially lethal, of course. This cracks me up. You'll see this in the books. It's a curable form of hypertension. I'm like, that just sounds silly to me. But what they're referring to is the fact that somebody like myself that has essential hypertension, I take my lisinopril, I cover up the fact that I have essential hypertension, fix my symptoms and my blood pressure is normal, but I didn't fix anything, I'm just covering up the fact that I have high blood pressure. Where with pheo, when you take out the pheochromocytoma, you have fixed the blood pressure problem, so that's why it's a curable form of hypertension. I put that in there just because when I read that in one of the books, it made me chuckle. The cause is unknown. Usually it is an isolated tumor on one of the glands. Boys and girls both get it. Typically, it's just kind of a middle-aged adult kind of issue. And then they talk about this 10% rule because 10% of the time it can be bilateral, 10% of the time it can be malignant, so not very often. Extrarenal possibly. If it is extrarenal, the next place we immediately go look is in the aortic arch. That's the most common place that an extrarenal pheochromocytoma will show up. And then kids can get it, but it's rare. So most of the time, like I said, it's on the adrenal medulla. Most of the time, norepinephrine, sometimes a little bit of epinephrine, but most of the time it's your norepi, secreting tumor. Okay, and that's what we're going to talk about today. There are secreting tumors that are epi-secreting tumors. There are dopamine-secreting tumors, because these are catecholamines. Okay, we're going to talk about norepi today. But what's really, really, really important when you're doing the pheo, do you remember what kind of secreting tumor it was? Was it norepi or?
I believe it was norepi.
Norepi, yes, that's the most common. So, but we need to know what it is up front because you're going to treat your swings of your hypertension in the OR differently depending on what catecholamine is being secreted from the pheochromocytoma. Classic triad, these episodic swings of headaches and blood pressure, okay? And so these folks will be cruising along and I'll be right here and my blood pressure is great. And then all of a sudden, just out of the blue, my blood pressure is now 250 over 150. And I got that raging headache. And then a little while later, wow, I'm feeling better. And now my blood pressure is back down to normal. So you got these episodic swings back and forth as that pheo is excreting the catecholamine. Those blood pressures are going up and down, okay? And remember that it depends on the type of catecholamine that's being released. If it's a norepi, you're going to get all the alpha effects and the vasoconstrictions and whatnot. If it's an epi, you're going to get the beta effects, okay? So you can see your hypertensions, reflex bradycardia with the alpha, more of a tachycardia with the beta effects. If you think about an alpha, a norepinephrine secreting catecholamine just to get it in your mind how intense this is, we use our neosynephrine, we pull up that 1 milligram vial, we draw it up in like 100 cc's and you put it in there, and then you get the 100 mics, or you pull it up in 10 and then you dilute it again, you double dilute it to get your 100 mics of your neosynephrine, your phenylephrine. Take that 1 cc vial, just inject it. Okay, that's how intense the pheochromocytoma can be, norepinephrine secreting pheochromocytoma. Okay, so think of it kind of that way. You're like, oh my goodness, that is huge. Of course, there are high-risk cases. The one thing that's really kind of interesting here that I ran across also is the fact that, and think about this for a minute. What they're saying is that 25%, 25% of people that die in the hospital with an unrecognized or undertreated pheochromocytoma, 25% of those folks that die in the hospital that have an unrecognized or undertreated pheochromocytoma do so on induction of anesthesia. That scared the heck out of you? 25%. Okay, so now these cases, like you knew this patient had a pheochromocytoma, so you know that up front. Okay, but I start worrying about that rare occurrence. Oh my gosh, somebody that comes in that's either not recognized yet or not being treated very, very well yet. 25% of them can die on induction of anesthesia. That's a scary fact to me. So we need to get these folks on some sort of alpha blocker, like a phenoxybenzamine. Okay, was your patient on phenoxybenzamine, do you remember?
No, they were on doxyzocin.
They were on the peroxyzocin? Yep, okay. So another one that they use though is the oxybenzamine. Works really, really well. The trick with the phenoxybenzamine is that you need to stop it, okay? At least 24 hours, preferably 48 hours before surgery. Because if you don't stop it, and let those alpha receptors reset, you can get massive hypertension on induction, okay? So this, if they're on the phenoxybenzamine, you see that on there, and you realize that they took their phenoxy that morning, the surgery, that is a very, very valid reason to cancel the case, okay? Because they can get very, very hypertensive on induction, okay? Your prazosins, your doxyzocins, typically you can continue those all the way up till the morning of surgery. I bet your patient was still taking those, is that right? Or
Yeah, along with metoprolol.
along with the metoprolol, exactly. So you have with the beta blockers. So very good. So thank you for bringing up beta blockers. So with these folks with this norepinephrine secreting tumor, we need to get our alpha blockade up first, okay? We start giving them beta blockers before we get the alpha side blocked, and you'll get unopposed alpha. Severe hypertension, okay? So definitely you gotta get with these guys, you gotta get your alpha blockade going first, your prazosine, your doxyzocin, your phenoxybenzamine, before you would get them on the beta blockers, okay? So keep that in mind. We're looking at, I've got here end organ damage. Remember, these are the folks that you're upregulated, okay? We've had blood pressure issues up and down with all the organs, so end organ damage. So I start thinking in these cases, can this person have other issues, other heart disease issues or whatnot? So I'm gonna be definitely saying I need 12 lead EKG, I possibly need an echo, those kind of things, because I worry about other end organ damage. Did you do it laparoscopically?
Robotically. Yeah.
Robotic, okay, fantastic, cool, yeah, so laparoscopically. So a lot of them are done laparoscopically now. I come from the day, unfortunately, that it was all open procedures. So that's why I think I have up here, plus minus epidural with laparoscopy, you probably don't need the epidural. The one thing, if the epidural is in, thing we learned right away is that's great, you can use that for post-op pain management. Definitely you're not gonna dose it up front. You're gonna wait till the end of the case, because you don't want all of that sympathectomy when you get to phase 2 in the operation, so cool, okay. So phase 1, all the way up from induction to when they clamp the vein. And then that's where you're gonna see the hypotension. Did I say hypertension? The blood pressure is up, okay? Because the surgeon is manipulating that tumor, so it's releasing the catecholamine, in this case the norepinephrine. So you're gonna be needing to be treating that and using short-acting stuff because you don't want, a long-acting, say, beta blocker going, and then all of a sudden you get to phase 2, they've now clamped the vessel, and now you get into that spot where now we don't have all that big catecholamine rush, and you get to the hypotensive side, okay? So short-acting things. Definitely large varieties, I put plus minus central line, because nowadays, the pendulum goes back and forth, and nowadays we really look closely at central lines, the risk-benefit basis of them. Definitely A line, and definitely you can be thinking on a case-by-case basis, depending on like what end organ damage or whatnot that they have about PA or GE. So did you have any of that stuff going with it too, or just A line?
Just a A line and central line.
You need that central line. So excellent, very good. Keeping them deep. Remember, these folks have a lot of sympathetic system stimulation, so definitely keeping them deep on induction. Okay, we don't need any more excess stimulation. Insufflation, keeping them deep for that. You don't need any of that excess insufflation or stimulation. You just put them to sleep. Normally, you love that. Maintenance smooth for, of course, kind of deal. But keeping them deep. Okay. So on that first phase, and I said, standard. You can argue desflurane, plus minus on desflurane. Some people argue with desflurane about tachycardias and hypertension associated with that. But typically you're going to be using your niprides and your phentolamines or whatnot, short-acting stuff to deal with your hypertension. Did you guys use magnesium for hypertension? Were you doing that? No? Okay. You use your niprides and that kind of deal. Yeah. You have all that stuff ready to go. Okay, because was it up and down like that through the case, or how'd it go?
It was actually pretty stable.
Stable?
Perfect.
We did a slow.
I'm gonna actually have you use your mic because these guys are all looking out there.
Yeah, we did a slow induction, and we used rock to paralyze we gave some esmolol prior to DLing, and then throughout the case, she was actually pretty stable. We had cardine on at like 5, and we also had nitroglycerin on standby, but we never had to use it.
Really? Okay.
Yeah.
So it went well.
Yeah,
That's
yeah, no, it
what
went
sounds
really
like.
well.
You didn't have the big swings or anything.
No, I mean by the time they clamped the vein, she was fine. She didn't even
Right.
drop that much.
Right.
But we turned off the carding and then just turned on a little bit of phenylephrine, and she did great.
Right. Okay. So you turned that on after they clamped the vein.
Yeah.
Yeah, exactly. And then she stayed. Blood pressure stayed well then.
Yeah.
So anticipating, right?
Yeah.
Yeah. So all of a sudden you've taken away that the catecholamines. Excellent. Good deal. So cool. And using short-acting stuff. So I also think I have up there glucose, as we know. Catecholamines mess with your glucose control, so we're monitoring that. Were you monitoring that through the surgery, or
No.
Not so much? Okay, so a lot of times folks will do that, and definitely afterwards. Drugs to avoid, so Reglan, Composine, Phenergan, these guys all have been shown to cause a potential hypertensive crisis with somebody with PL. So we want to stay away from those. Glucagon, I'm still struggling in my mind why glucagon, but glucagon has been shown to release the catecholamines from a PL. But I haven't given glucagon for a pheochromocytoma, but I guess it's a possibility. And then in theory, morphine, tracherium because of histamine release. drugs to stay away from. Afterwards, monitoring glucose again, because the glucose, how the catecholamines affect your glucose. How come 50% of these patients you've taken away? I told you it was curable. We fixed their hypertension. How come 50% of the time we still need to continue with blood pressure medicine? Because still the catecholamines circulating around 50% of the time. Then in 20 to 30% of the time, these folks will need to be on antihypertensive because we just uncovered that they had essential hypertension underneath the phenylchromocytoma that was born. So, scary fact, hypotension, most frequent cause of postoperative mortality. We have to be watching these folks closely in recovery and closely when they go back to the floor or whatnot. You guys went, I'm assuming, back to the recovery room, or did you go to the unit?
No, Packy.
Yeah, you went back, exactly. Okay, because remember, these folks have been upregulated. They're used to that blood pressure being a little bit higher. So when we start thinking about, well, I'm okay with a patient having a mean of 60, these folks maybe not so much, okay? Most frequent cause of post-op mortality. And unfortunately, I'm gonna stop right there with 10 minutes to go. Is that gonna make you mad? You gonna be sad about that? No. Questions? Well, enjoy clinical, you guys. I'm glad you're all back. I'm glad to see y'all.